Good afternoon, colleagues, ladies, gentlemen. During the next 10 minutes, I will be talking to you about evidence-based policymaking and tackling the oral health data gap that exists. In fact, going back to 2007, when there was the 60th World Health Assembly on oral health, it already recognized the need to strengthen oral health research and to use evidence-based oral health promotion and disease prevention in order to consolidate and adapt oral health programs and to encourage the inter-country exchange of reliable knowledge and experience. In fact, when I looked up evidence-based policy, it is all based on evidence-based medicine applied to public policy. Many policies are taken by groups of people coming together, experience, and the reason for this is sometimes the lack of data available, maybe they are not aware of it, and also sometimes the speedy need for a quick decision. This is a picture taken in Malta 2 days ago. We all know we're facing economic difficulties, but also this climatic change. That was Malta, sunny Malta meant to be, but we had 3 storms in a matter of 24 hours. So important that the evidence we have is evidence, the research, the policies are evidence-based in order to target the resources that we have available. If we look at the data gap, the current situation, there is lack of routine, available and comparable EU oral health data in the incidence and prevalence of diseases in the dental workforce, in expenditure on oral health care, as Ken was saying, the difficulties in quantifying out-of-pocket expenditure, the economic burden of oral disease, how do we quantify it, and cost-effectiveness studies of preventive initiatives. But if we look at the crunch, where does the data gap exist? It's in definitions, in the methodologies used to gather the data, in the use and interpretation of the data, and in monitoring of the data. If we look at definitions for oral diseases, we go back to 1999 to 2010, that all researchers cite that there is no accepted definition for periodontal diseases. We look at Demmer and Papapano, that the criteria used to define periodontitis differed substantially between epidemiological studies. We look at Savage et al. An agreement of definitions was rarely found. And many definitions of periodontitis have been used in the literature, but there's no accepted standard. So we can see how can we compare periodontal disease in different countries if not even the definition is the same. In fact, it appears in everyday life. I was on one of my travels and I came across this definition. So you wonder, how can we have consistent definitions? There's also a lack of consistency in what defines caries in epidemiological study. Some studies quote, its first picture we can see is it early stages? Is it cavitated stages? Is it by visual detection? Is it by visual tactile? Do we use radiographs? So there's large gaps in the data. We also have gaps in the methodologies used to gather the data. In fact, epidemiological data relating to tooth decay and periodontal disease are particularly unreliable. The data is either estimates or collected using different methodologies, and this limits the comparisons between EU member states. In fact, Leroy et al. In 2010 highlighted the problems with regard to collection of reliable data on periodontal health. In fact, a Medline search carried out in 1999 put in periodontal disease and epidemiology, and all the different methodologies used, they couldn't even find a consistent result. And another example I'd like to give, that in 2000, 2 surveys were carried out on dental caries in Portugal. One gave a DMFT, which is the decayed missing and filled teeth value in 12-year-olds of 3.08. And another study carried out by Almeida et al. Reported a DMFT of 1.5. This is from the same country, in the same year. But when you actually looked at the methodologies, the General Directorate carried out a representative sample in all of Portugal, including the islands, whereas the second study carried out the study in only 5 regions of the area, did not include the islands, and was carried out in 16 schools where consent was given, probably the more affluent schools. So you can see the difference in the 2 values. So this is a problem with using the data that we have. In fact, That's my next point, the use and interpretation of available data. This is often not fully understood by people quoting them. Studies are quoted without investigating the validity of the study or the reliability of data produced. In fact, in the CCDO database, all references to DMFT are cited. So people can look at the methodology to know if they want to use and quote the data or refer to it. It is not pertinent to make a direct comparison of DMFT scores between individual member states. In fact, if you see a slide I got from a publication, the data was sourced from the WHO database. But here, in a slide like this, I know it's too small, the fonts are too small, but we cannot say that one country has a better DMFT than another country in a report like this, because they have used different methodologies. Some are from national surveys, some are from local cities, and some of them date from 1988 to 2005. So it's very difficult to compare if you're not comparing like with like. The important also is that the data is monitored, that whatever system is introduced, it has to be validated and continually monitored, especially as new evidence emerges. So what has been done so far? We know that WHO has published an oral health surveys guide, and this was intended to be able to be used throughout the world and not specifically for Europe for basic oral health epidemiology, and in fact is currently being updated. Then we had 620 indicators were initially identified in 2004 by Bourgeois et al. However, 620 indicators is a bit time-consuming and a bit difficult to utilize. And then the European Global Oral Health Indicator Development Project was introduced, and they tried to address this problem and came up with 40 indicators to assess oral health in Europe, but these were not supported by consistent, comparable, and updated data. One good thing that was done was that because of the inconsistency in the definition of dental caries, the International Caries Detection and Assessment System was developed. And apart from this, the WOHD also proposed the development of a European oral health surveillance system by using Sentinel general dental practitioners to be used to collect surveillance data after they were trained. This was a good idea. However, the model may be more readily applicable in countries such as France and the UK as compared to other EU member states such as Greece and Spain, where it's reported that less than 40% of the population attends a dentist in any 1 year. So what needs to be done? We need to bridge the gap. We need to bridge this lack of oral health data gap. We need to develop an oral health epidemiological infrastructure that assists in oral health strategy and policy development. We need to establish a European consensus on definitions for all diseases to be used in epidemiological surveys, and develop common methodologies in the data collection process within EU countries, acceptable within the EU. And we need to disseminate all the major research outcomes to policymakers, stakeholders, and as we heard before, not only dental stakeholders, but all the stakeholders in health, outside health, the other impacts, the social environment, which all indirectly or directly impact dental health. This may involve creating and financing a European infrastructure, which could be done by the platform, importantly done in collaboration with all major stakeholders, all interested bodies, come together to bring about this bridging of the gap. So we see if we get high-quality, comparable data, we're going to have more evidence-based oral health policies, reduction in the inequalities of oral health. In fact, reduction in inequalities in health was one of the resolutions of European Parliament in 2011. We're going to get better oral health in Europe, and as somebody said before, better oral health for less, and we get better quality of life for all EU citizens, which is ultimately the goal of all of us here. Thank you for your attention, and if Teet could talk, our life would be much easier.